I would like to welcome everybody to today's Cardiology Grand Round. It's my great pleasure to introduce Dr. Bo Yang, who is talking about surgical management of aortic valve disease. Dr. Bo Yang is the Chamberlain Professor of Cardiac Surgery, and he also directs the research at the Department of Cardiac Surgery very successfully. And I got to know Bo over the last year as a co-director of this MI-Aorta program. Dr. Yang received his MD degree from Yunnan University in China, where he also currently holds an honorable professorship at the same institution. He received his PhD in pharmacology at the University of Arizona, and he stayed on for a residency program at the University of Arizona in general surgery, and that was followed by a fellowship in CT surgery at Stanford University. He is at the University of Michigan since 2011, and he has developed a strong clinical interest in complex aortic surgery and aortic valve surgery. Research interest is on cell mechanisms of genetically triggered aortopathy, and his research was supported by a KO8 and currently by 2 R1 with NIH grants. In his laboratory, he is modeling UVs with iPSC cells, and he has published over 111 manuscripts. So with this, Bo, thank you so much for giving us an update on aortic valve disease.
Thanks, Marianne. Thanks for the nice, kind introduction. And I know most cardiologists here, my colleagues and friends, and work together. We rarely have party together, but sometimes we'll party together, which is good. And so I gave a talk before about the valve spin roots. Today, I want to talk about this aortic valve disease, since there's some changes. Number one, including aortic valve repair for the aortic insufficiency. Number two, aortic valve replacement. And because the TAVR is really taking a lot of patients, doing a great job for that. And I want to show our cardiology colleagues what we have been doing in surgery, what advance and what been achieved in surgery to serve our patients better. And so I will focus on those two diseases and treated with the operation, so open operation surgery. So aortic valve diseases, so we talk about AS-AI, there's others, aortic root aneurysm, which involves the valve. And it's always interesting, this is, people easily get confused about the aortic valve replacement as aortic root replacement. Aortic root replacement actually including the valve replacement. So it's much more complex operation. And for root aneurysm, you do valve spin roots. Valve replacement is one component of the aortic root replacement. So it's very simple, or it's a simple operation. I'm not going to discuss about the endocarditis or aortic dissection today and focus on the top three. Aortic root, it's actually in the definition of the aortic root, it's not clear to most medical professionals, and my residents, they don't know. It asks them what's the difference between the valve, aortic root. If they don't know, they don't learn. Most time they don't know the difference. There's 10 things I teach them. Aortic root, aortic valve, just one thing of the 10 things. So number one is the anatomic aortic annulus, which is completely different from the annulus we say by a cardiographer. Like Choi, I saw him today. He measured the basal ring diameter. That's the basal ring diameter here. It's not aortic annulus, anatomic annulus at all. It's just the function, the basal ring diameter, blood flow. And the crown-shaped aortic annulus is this shape for the valve to attach to the aortic root, aortic sinus. So that's very important for us to put stitches to hold the valve. The second is two coronary ostia. That's easy to understand. The three cusps. Three aortic sinuses. Those are easy to understand. Three interleaflet triangle. That's the difficult part. It's between the cusps, interleaflet triangle. That's what we can do a lot. That's membrane septum, conducting system, muscular septum, all those things. So those people ignore those three things about the aortic root, but that's very important for surgery. And the four rings 4 rings, basal ring, I mentioned, that's the echo CT measure the aortic annulus diameter of basal ring. And then VAJ is junction of the ventricular and the aorta, it's junction here, which actually is, for us, it's important to dissect it down below the VAJ to this level for valve spinal roots. And also the STJ, that's another landmark for TAVR and for SAVR, both important for root enlargement too. And then this the ring of the aortic sinus. So those 10 things for a surgeon, aortic surgeon, you have very clear mind of those 10 things to really to do a aortic valve repair, valve spinal roots, annular enlargement. 3 things surprisingly to keep the valve competent. Only 3 things. Number 1 is the basal ring here, function annulus. This annulus dilates, function annulus dilates, valve leaks. Cusp has a hole, valve leaks. STJ dilates, valve doesn't come together, valve leaks. So any valve, aortic valve repair will have to think about 3 things and how to make the valve competent. It's a little bit different from mitral valve. Mitral valve have 1 mitral annulus. These have 2 rings, very important, the basal ring, STJ, and the cusps. So we're talking about aortic sinus size. It's nothing to do with the competency. You have a large root aneurysm, but STJ, basal ring, cusps are normal. Patient doesn't have AI. So this is a classification of the AI. You come from STJ dilation, leaking in the middle. So this STJ dilation and also the annular dilation with valve spinal roots, cusp leaks, and this is just pure the basal ring dilation, annular dilation leaks. That's type 1. Then you have a hole in the cusp, or prolapse of the cusp, or restriction of the cusp. So also the mechanism of aortic valve leaking, AI. We repair the aortic valve, we have to understand the mechanism before we do anything. And this is very important for us. So for the STJ dilation, we very frequently see with ascending aneurysm, pull the STJ apart, they have central AI, which can be very severe. What do we do? And we placate STJ back to normal size. It's about 1.2 to 1 compared to the ratio of the STJ to basal ring is about that's kind of ratio 1.2 to 1 in adults, especially in older people. In younger people, just 1 to 1. Sometimes the cusp is thickened by the AI. We shave the cusp to make it competent. We have to placate each coronary sinus proportionally because they are not equal. You can see this sinus smaller, this sinus bigger. If we placate equally, then this cusp will prolapse. The AI doesn't resolve. So it's a surgical technique. This is one type of AI we fix, reconstruct STJ. Second one, you have the valve prolapse. You can see the right cusp is prolapse here. So we placate the right coronary cusp, make it competent. It's another technique. The bicuspid valve, this conjoined cusps, the prolapse. We placate the frame margin of the cusps, repair this valve. However, most of the time, the bicuspid valve patients could have the annular or the basal ring dilation. So we can do a external ring, which actually is a band of a Dacron graft, make the inner diameter of the annulus from like 28, 32 to like 23, 22. So that's a big placation and with the external ring here. And this part of dissection actually is quite deep. It's a little bit tedious from surgery standpoint, but that fixed the mechanism of AI. So here's another patient, bicuspid aortic valve, we resect the raphe, makes the coaptation perfect. Then we did STJ reconstruction, different combinations. This one we did the non-coronary sinus resection, STJ reconstruction with the graft and the external ring to fix the aortic annulus. We also did the cusp placation to treat the prolapse. So bottom line is we do aortic valve repair and or have the based on the mechanism of AI, then we can treat the AI and accordingly and fix the mechanism, fix the AI. So next is the valve sparing roots. This is another bicuspid aortic valve. You can see the left and right coronary artery came out of same sinus. The valve is perfect. The key thing for valve sparing roots, you really need to dissect it down below the nadir of the cusps, which is very difficult to do because basically we have to roll the RVOT off the LVOT. We have to cut into the muscular septum by 1 to 2 centimeters. That's very dangerous. You cut either way, you cut the left ventricle, patient bleed to death. You cut the right ventricle, patient could bleed to death. So it's very tedious dissection. If we don't do this part dissect this deep to have the graft in case the aortic root annulus, then this part of the nadir of the most time right coronary cusp can herniate out the graft and cause prolapse of right coronary cusp because of AI. That's the most common mechanism of a failed T-David valve sparing root replacement. So the first time when we do this operation, we pay a lot of attention to this. That's really down. And once you get familiar with anatomy and surgery, and it's tedious, but actually it's very durable. So this is the Malfans patient that did the 2 grafts, recreate the sinus of Valsalva and the ascending graft. And the people like to use other Valsalva graft. The reason I don't use that is Valsalva graft, you have a side of Valsalva graft, the diameter of STJ, basal ring, the height is all fixed. It's just like, you go to Macy's buy a shirt, it's a medium size, everything's fixed. But they go to tailor and they'll measure you, your armrings, your waist, your chest, all those things, then you tailor the shirt to you. So, and use 2 grafts, you tailor the graft to the patient. Use Valsalva graft, basically you use the patient to fit the Valsalva graft. It's all fixed. So this is an example here. So this compression post is really high, it's about 2 centimeters higher than other 2, same as this case too. So if you use Valsalva graft, you cannot suspend those because you have to suspend the same as say STJ, which is fixed. So we can do it with 2 graft technique. You can suspend anywhere the valve wants to go. It's not the graft wants to go. So then you make the valve competent. You can tailor the small graft just then to the larger graft. Eventually, you say end up like this, not like the first case I showed, because this compression post is much higher. This patient is about 5, 6 years old now. The valve is still competent, no AI. I just saw him in clinic actually. This might be a video here. Yeah, so I'm showing the valve here to make sure it's competent here. So it's good. Yeah. So there's a benefit of saving the aortic valve. This is our study from our data. So this is the valve sparing roots. This is a mechanical valve and the tissue valve. Bentor just replaced the whole root with the tissue valve, mechanical valve. The valve sparing roots, actually patients, it's 8 years now, the survival is significantly better. So you save patient the valve, it's much better. Now, hemodynamics better, it's more resistant to infection and endocarditis, and I'll show you how to make it competent. So I think it's much better for the patient if you can save the valve. So summary, for aortic valve insufficiency, first we should consider aortic valve repair. If it's repairable, repair it, save the valve, better long-term survival. And if patient has a root aneurysm, and we should do valve sparing root replacement. No matter bicuspid or tricuspid valve, we should really save the valve for the patient. And if patient valve is not salvageable, sometimes it's second or retracted, it's not good anymore, so then we need to replace it. So in the next question, we'll replace the aortic valve. What's new now? What we can do differently? And this comes to the AS patient. The AS patient, you can look at this aortic valve compared to the valve you showed. Can you tell this is the aortic valve? It's just a bunch of sand and rocks, everything. And I couldn't even find the opening of the aortic valve. This is the case I did on Monday. It's a crazy patient to live with this. I mean, she's in severe heart failure, EF 20%. So, and those patients, if we do TAVR, and it's very easy to drop those sand and clot causing embolization. And distally, like no strokes or distal toe, limb, got embolization. But anyway, so this patient will put a 27 largest mechanical valve. He's young, he wants a mechanical valve. So aortic valve replacement. That's one thing I realized in the past few years. The label of the aortic of the valve size has nothing to do with the valve size, valve the opening. This is a 25 size valve, or they label 25 because they say the ID is 25. But the ID is not the valve here, ID is the instant ID. Then you have a cloth, you have everything, you have those things, they don't tell you. So I try to put a 24, ID is 24, I put a 24, you can never pass a 24 sizer. I can only pass 22 sizer. I can only pass 21 sizer here for a 25 size valve. So when I put it in the patient, the tissue, the annular tissue come in, make it even smaller. It's about 5 to 6, 7 millimeters smaller. Some patient surgeons use pledges, make the opening of the valve even smaller. So this is, from that time, I measured the valve size for every single patient I put a valve in. So this 25, you measure it only can pass 20 millimeter. I don't use pledges. You cannot narrow the inner diameter of the valve more. So 27 is 22, 29, it's only 23. You think about 29 valves, the largest valve is 23. Most common valve we use, the surgeon use, is 23. The inner diameter is about 16 millimeter. Think about this. This is another measurement from CT scan. All patients have a 23 millimeter annulus. If you have just 23 McLean's valve, the inner diameter is 17 millimeter. This is top head, 27, the biggest top head valve, inner diameter 23. Say your 29 McLean's valve with inner diameter 23 just matches the original size of the patient's alveolar annulus. So you really need to upsize by 3 valve sizes to really match the patient's native annular size with the inner diameter of the valve. If we do a calculation, if we don't do any annular enlargement, just say patient come here 25 or 25 valve, 23 valve, you do a calculation, we immediately reduce the annular area by 36 to 56%. That's why every patient with a normal annulus, 19 to 25 come to us, we'll put a valve in without upsize the valve. We give them PPM immediately. Every valve has a PPM if we don't do annular enlargement. Every patient with normal annulus needs an annular enlargement. So TAVR valve is the same thing. 23 absolute, I don't know what 23 means, but the inner diameter is 15 here to here. And this is sapien, it's 14 to 15, this is 23 sapien. Same thing, I don't know how they label it and what it means. We have to measure the diameter ourselves. In all the trials, partner 1 to 3, the pivotal trial, low risk trial, all the trials, and only 1 to 4% of patients had annular enlargement. The most common valve with surgical use was 21 to 23. Basically, we give everybody PPM. I mean, the moderate to severe PPM is 50 to 60%. And I mean, we don't talk about mild. If I'm getting AVR, I really don't want, my annulus was 21. I really don't want surgeon to give me a 21 valve. I want them to give me a 27, 29 valve. That will, and then I can still run. I can still play tennis. So this study from us, you see, this is 29 valve, this 23 to 27, we'll combine them together because their K-M curve is very close. It's 19 to 21. That's obvious survival benefit. 29 valve survive much better. 23 to 27, second. 19 to 21. We surgeons should not put a 19 or 21 valve in patients at all. That's just period. It shouldn't. This is just multivariable analysis showing the small valve has much higher risk, like 19 to 21. The odds ratio for optic mortality is 11%. Patients have this valve had 11%. I'm sorry, not 11%, 11-fold, 11 times higher optic risk. And the long-term survival has a rate of 2.5. It's very significant. We have to give our patients bigger valve. Actually, we learned this from TAVR. Without TAVR, we don't even compare those things. Now we realize surgical valve hemodynamics is so poor. We'll have to upsize the annulus, give bigger valve. So think about a patient with the annulus 23, you can have a 23 valve, 29 valve. With the 29 valve, better hemodynamics, better survival, better longevity of the prosthesis, and a much better setup for valve in valve TAVR in the future. This is very important for lifetime management of aortic valve disease. So let's talk about the annular enlargement. The annular enlargement, I mentioned the confusion about the basal ring, which is measured by CT and echo, and the anatomic annulus, which is this crown-shaped red line here, where we put stitches. Annular enlargement, the goal of annular enlargement is to enlarge the anatomic aortic annulus, open the root, put a large valve in the root with the inner diameter match the basal ring and the LVOT. We do not put valve into the basal ring, so we do not need to enlarge this part because patient was born that into adulthood unless he has some congenital problem. This is normal, LVOT is normal, basal ring is normal, don't need to enlarge. That's old technique, all develops. The old technique for annular enlargement, we all cut down. So this is cut down through the non-coronary sinus into the mitral valve. This is Nix. This is Manugan, cut down from the left non-commercial post into the mitral valve. Just cut straight down to the colon procedures. Same thing, just cut down from the aorta through the basal ring into the LVOT, cut the septum, muscular septum. The deeper you cut, the larger the top, you can enlarge more. Basically, the anatomic annulus has enlarged more to put a bigger valve here. However, when you cut down into the mitral valve, the ventricles like this, there's a lot of risks, right? There's the risk of mitral regurgitation long term. There's risk of the fistula from aorta to RVOT. I have fixed that before, and the patient had this colon down a long time ago. Can have heart block because conducting systems in here can have bleeding. Adult surgeons don't do colon because it's just too much construction there, and the adult surgeons don't do well with that. So we come with a new idea in 2020. After 2020, instead of cut down was Y-incision into the LVOT. Here we develop Y-incision, which split the left non-commercial post and open the aorta mitral curtain both ways and put a very large patch here. By doing this, we enlarge the aorta mitral curtain posteriorly tremendously, and enlarge the root, enlarge the STJ tremendously. So this is the annulus, basal ring is 23. We put a 29 valve there. Look at the inner diameter, just match the 23 perfectly. It's not oversized. It's just the size patient need. Need a 3 to 4 valve size is bigger. So this operation, even patient with the anomalous circumflex, we can still do this. We can dissect circumflex off the root and then enlarge the annulus as we did and upsize to a 29 valve. The valve is above the dome and the circle. It doesn't stretch the circle at all. All right, I'm going to show you a quick video here, and you can take a look at how we do this procedure and just get a sense. So we dissect the circumflex off the dome and the root. So that's the circle there and more dissection. So see how small it is. Now we open it up, cut it down into the aorta mitral curtain, open both ways. That's the right fibrous trigon. See how tough it is. See, the root is wide open now. So we'll put a big patch there. So from the left, the fibrous trigon, which is related to the mitral valve, to the right fibrous trigon, and patch it up so the aortic annulus. So now the root is open, wide open, and the patch bulges to the transverse sinus, which is empty space. It doesn't damage anything, doesn't compress anything. So it's a very safe space for us to do the enlargement. So we transition to the aortic annulus, just sew it up. So it's on the left side, we sew the patch to the left coronary sinus through the aortic annulus. This is not a redo. We frequently have done redos with patients with 19 valve upside. Redo will be more complex. So you can see the root is wide open now. This is 29 valve size. We put it there, we mark it. The valve sits very well. So put the valve stitches there. I do not use pledges because pledges does crowd the LVOT, make the annulus even smaller after the replacement. it's a very pleasant operation because the root's wide open now. Everything you can see clearly. This is my fellow doing it. Most time my fellow doing the case, but she was a little nervous about the circumflex. She asked me to show her, so I did the majority of the case. So this is how you put the stitch through the patch. Then you see the valve there, and check the coronaries, and make sure one strut is facing the left long commutator post, and I want to block the left, right coronary ostia. So we tie it down. But I do not use corners. I try not to leave any more foreign body patients don't need. Just tie with the fingers. So you can see this valve is wide open and the LVOT is wide open. Then this is one interesting technique we developed. Because most patients, not just root small, the ascending aorta small. So we open the aortic ascending aorta longitudinally, make the proximal ascending aorta much bigger. So it's very easy for TIVA because they really have no sequestration of the coronary. It is TJ. So if you put a valve in valve TIVA, it works perfect. So we just close the aorta. Yes, this Dr. and Barbara Hamilton doing from that side, I do it from this side. So see the triangular shaped patch incorporated into the longitudinal autonomy to enlarge the proximal ascending aorta. So not just close the whole aortotomy with the patch. You can see the valve sitting there very well, and there's a lot of space for the valve. So you can see the patch is posteriorly right here, the circumflex is down there, and if the redo operation, we can easily just do the anterior part, leave this part unknown. And we try to minimize the very foreign body as much as possible. It's needed. Okay, let's go next one. So this approach is very good for prosthetic valves. It's 23 annulus for 29. You can see the root is enlarged very nicely, uniformly, and the CT scan showing very well. The valve sitting in the middle, a lot of space between coronaries and the valve, and the LVOT just matches the inner diameter of the valve, which is perfect. So it works for mechanical valve too. It's a 19 millimeter, very small root. See here, we enlarged it, put a 27. The hemodynamic is so good. She's very big. After this, she feels so much better. She's trying to lose some weight. So we have done probably my post about 80 now. My colleague together is about 120 probably. You know, this is serious. It's the patients, majority is female because they are small annulus. Half of them obese. BMI is about 30. Annulus about 21. Or up on 3. Yeah, you can kind of see here 3 to 4 valve size. The valve implant. Can we get rid of this again? It's about 27, 29. So that's not many complications, except the one patient had strokes, and no 80% didn't have blood transfusion, despite this 1/3, more than 1/3 had reduced and no mortality, no optimal mortality. It's actually quite a safe procedure to do. So here's the other details. The blue line is up by 3 valve sizes. The yellow line is up by 4 valve sizes. Majority of patients about 3 to 4 valve sizes. The red line is 2 valve sizes, but almost of them reached the largest valve sizes. The green line is 5 valve sizes. And yeah, sometimes I don't know how to get the 5 valve size, but we did. So you cannot see here. I don't know why the bar has to be here. We cannot get rid of the bar and can we move it somewhere. Yeah, we can. So the most common valve we use is 29 or largest mechanical valve, which is 27. Yeah, the gradient post-op 3 months, a year after year, it's about 6 to 7. It's probably the lowest gradient compared to any gradient reported in the trials, including SAVA and TAVA. And the patient felt much better with nodular valve. You can see here, and the gradient is down. The index aortic valve area index 1 because of majority of our patients are obese and female. That's why, and the index could be even bigger. And the root enlargement from 27 to 40. So here's the thing, here's interesting we're doing now. And since 2020, August 2020, our institutions, everybody's doing it now. And in 2022, almost 50% of our AVR had annular enlargement. If you look at the STS database, less than probably 1 to 2% AVR has annular enlargement. So we are way ahead of the whole country. So the medium size we put it in after annular enlargement is 27. If we don't do it, it's 25. 27 is better. And not just our institution, so we host a wet lab. We have surgeons, senior surgeons from all the hospitals in the state of Michigan. And my colleagues, Dr. Kim, Alawadi, Gaurav, Dr. Patel was not in here in this picture, was the faculty teaching them how to do this operation. After this wet lab, the state of Michigan, the valve annular enlargement increase, we started here September, increased, no, actually September, maybe this year, started increase from 5-7%, 13%, now it's 17%. Actually, it's still going up more and more. More and more surgeons and hospitals asked us to do more wet labs. The valve size in the state of Michigan from 23 to 25 now. Michigan is actually doing very well with this. The final touch is, and if the patient has small annulus or a large aneurysm, so we need to replace the root, we cannot enlargement. So what do? So we create our own composite valve graft with much larger valve, up by 2 or 3 valve size, either tissue valve, mechanical valve, put in a small annulus and also replace the aortic root aneurysm. So this is one scenario we cannot do annular enlargement because the root is so big. Okay, and then I want to say we can do lima, use lima to cabbage every patient, right? Mammary arteries. But really, that's standard of care now. I think for surgeons, for the AVR, the standard of care should be an annular enlargement and the AVR, not just put the valve in, give patient the PPME immediately. So, and this is very important to educate our other surgeons to do the same thing. And I'm teaching all my resident fellows, and everybody in our program has to learn and master this technique. It's not difficult. Actually, the good thing is this technique is not difficult. It's simple and effective. So the conclusion is for this presentation is number one, if it's pure AI, repair the valve. If you can repair valve root aneurysm, save the valve, replace the root aneurysm. If it's AIS, you have to replace, or AI, you have to replace the valve, enlarge the annulus, and give patient a much bigger valve, 3 or 4 valve sizes up. And the Y-incision that we developed here actually is very simple and effective. All right. Thank you for your attention. That's my presentation today. Welcome any questions.
Dr. Yang, we have a question in the chat from Dr. Hoffman. She was asking, what degree of aortic valve calcification is too much for a valve-sparing aortic roof replacement in patients with AI?
Oh, yeah, well, we have some valve cannot save, so replace it. We have to replace it, and then we take the valve out and we enlarge the annulus and give a bigger valve. Yeah.
Anyone in the virtual audience is welcome to take themselves off mute, or they can put a question into the chat, and anyone in the room can utilize the microphone feature to ask any questions they might have too. Yeah. Looks like Dr. Eagle has a question.
But everybody's asleep.
Yeah. Hey, Bo. Thank you. What a wonderful presentation. Can you hear me?
Thanks, Kim. Yeah. Thank you, Kim.
So here's my question for you. If you look at the different types of tissue valves available now, are any differentiating in terms of the biochemical nature of their, as they descend in their ability to be pliable? Where's the status of tissue valve survival comparing the various types that are currently available?
Yeah, that's a great question. And the patient, or we talk about just tissue valve, just say tissue valve. That's really a general term. Different valve have a really different performance. And if it's a wrap around the struts, we find out already by multiple brand, those valves don't last long. The mechanics just pull, the valve pulling on the struts has highest pressure point. So those valves last average 7 years. It will just deteriorate, and that's typically is trifecta and mitral flow. And Dr. Shinichi Fukuhara and read 2 papers about this. So we should not use this type of valve. And then you have the freestyle or the porcine valve standard, which is mosaic. Mosaic, the inner diameter is actually even smaller than the micron-E's, which is a bottom pericardium valve. And if we freestyle stainless valve, however, if you give large stainless valve, because the size of the valve, the basal ring is so big, they're not good for TAVR. So we started to stay away from the stainless valve now. The standard valve and the Edwards micron valve actually has been proved to be a durable valve in the market in the past 20, 30 years. They said they have a new brand, which is the Resilience. I think that's the valve. They always say they're better, but it's only 5 years come out in the market. 5 year outcomes, okay, it's good. But I haven't switched to that valve yet. They treat it with difficult chemical to make the calcification less likely. But we need a long-term data for that valve.
And as a follow-up question, we're seeing that Lp(a) is associated with valve calcification. Is there any evidence that when we replace a valve with one of these various types of tissue valves, that high Lp(a) levels in the blood correlate with fibrosis in those valves?
Oh, yeah, and we haven't actually surgical field. We haven't done that for the valve for the prosthetic valve. Nobody haven't do any research on that, so I don't have an answer for that.
Thank you so much.
Thank you, Kim. It's good to see you. I'd like to make another comment. People ask this question about the Ross procedure, and ask why we are not doing more Ross procedure. And the Ross procedure, to me, it's getting more popular now because of the publication from Ismail. We're a good friend. We talk about it. The Ross procedure always had the autograft in the aortic position started having probably in the second decade. He had the data of first decade, which was very good, which was good for most accident surgeons, including surgeons here. Patient with the problem Ross procedure is always second decade. I think the data, the survival of Ross procedure is better compared to younger patients compared to mechanical valve. One of the key factors, surgeons didn't give a bigger valve for those young patients. They give a small valve, so patients have PPM immediately after the mechanical valve replacement. I was thinking about if we can do another trial, Ross procedure versus the young people with the annular enlargement with large mechanical valve. That result might be better. The reason I say that is because Duke Cameron and Hopkins, he did a valve sparing routes for the Marfan's patient. Some Marfan's patient replace mechanical valve. Those Marfan's patients always have dilated annulus. They give the bigger valve. I asked him, he said most of them get a 27 mechanical valve, which is the biggest. So with that change, he didn't see any difference between the mechanical valve and the valve sparing route patients. So I think the bigger valve make a difference. The Ross procedure also has the risk of the right side, the RV failure, all those things make 2 valve problems. Not just the aortic valve leaking, then you have a PS, RV failure. So I don't think, I don't have the quite answer, but I think it will be interesting to do a trial, Ross procedure versus the annular enlargement and aortic valve replacement for young people, give a large mechanical valve. So yeah, that's my take on ROS right now. It's thinking about this, if you change to AVR with annular enlargement, which is much simpler procedure, to a double root replacement, you put two valve at jeopardy. So that's why I haven't I haven't been convinced that ROS procedure is a better operation. Oh, I made a good time. I thought I was going to take an hour. That's pretty good.
Dr. Yang, if you have time for an additional question. So I don't claim to be an expert on aortic root enlargement, but I am aware that there are different types of techniques that can be used. Can you compare the technique that you've been describing to other techniques that have been described? And is it always that this newer technique is kind of favorable, or are there some patients that using other enlargement techniques would be preferred in those patients?
Oh, that's a great question. Actually, that's a very good question. And so for the nicks, nowadays we don't cut down the mitral valve anymore. So we just cut in the aortic mitral curtain because the incision is so small. We only can up one valve size at most, And so for nicks and manuking have cut down the mitral valve. So manuking cannot be used when patient has mitral replacement, the mitral ring or annulus calcified of the mitral valve. That's for those two. I just talked about those two. Colon is different for P surgeon use a lot. For Y-incision, because we don't go down there, we're not limited by any procedure we do for the mitral valve. The only limitation I have found out, and the Y-incision is if the aortic mitral curtain under the mitral annulus, the whole thing is calcified up to the aortic annulus, then you cannot cut down there because you have no tissue to sew to. So I only had one patient like that, 82 years old, had a TAVR infected pseudomonal endocarditis. So I have to take it out. I couldn't do the enlargement. And the TAVR valve actually is small, too small, and he has PPM too. So I put a 27 Magna. I think it's pretty adequate for him. And I don't see any other contraindication or limitation with this new technique. And because, but we haven't done hundreds or thousands. So we're still in the early stage of this technique. But that's a great question. We'll learn more when we do more. So what we cannot do.